So does starting hormone therapy in perimenopause up to 10 years before menopause reduce your risk of breast cancer, heart attack, and stroke by 60%? That's what the headlines are saying. That's what the big doctor influencers are reporting. Wait till you get a load of what actually was found in research by Dr. Rachel Pope. We've heard about the 10-year window for hormone therapy, that it's safer to start within 10 years. Her new study suggests the answer might be yes, it's better to start during perimenopause, but not in any way does it say what you were hearing online and on social media. She used data from 120 million patient records, and we're going to dive into what that means. She was challenging long-held beliefs about timing, risk, and the power of estrogen. So in this episode, we dig into the confusion over Dr. Pope's findings, and we talk about what it means for you, what it means for your symptoms, and what it means for your long-term health. Today on the podcast, Dr. Rachel Pope, an obstetrician gynecologist and certified menopause practitioner in the Department of Urology with an appointment in the Department of Reproductive Biology at University Hospital's Cleveland Medical Center. This is Hotflash Inc.
I'm Ann Marie McQueen, journalist and proud 50-ish woman, and we are here looking for the true truth in perimenopause, menopause, midlife, and beyond.
Opening our minds to other possibilities is not always easy.
Hotflash Inc.
You're all woman to me. All right, Ann Marie.
I want to start off by thanking Bonafide Health. Bonafide was a gold sponsor of the Hotflash Inc Summit, managed to bring together 36 amazing speakers, not a fear-mongering person in the bunch. Bonafide provides novel, safe, effective, and research-backed solutions for women's health, from hot flashes and vaginal dryness to mood and skin changes. Bonafide is working to set a new standard for menopause care by bringing their trusted, evidence-backed options to the retail aisle nationwide in the U.S. at Target. Bonafide is providing millions of women with more access to science-backed solutions. To learn more, visit hellobonafide.com and be sure to use code SUMMIT20 to receive 20% off the first month of subscription of any Bonafide subscription product. Thanks again, Bonafide. I really appreciate it. Thank you for coming on the Hotflash Inc podcast.
Absolutely.
It's
great to be here.
Well, I've seen you all over sort of explaining this, and I thought I really want to talk to you about this myself because it's early in your research and it's going to be exciting to follow and see what you do. I'll just start off and say that the headlines and the reels and the Instagram posts about this were that if you start hormone therapy, estrogen therapy during perimenopause leads to approximately 60% lower odds of breast cancer, heart attack, and stroke. And I think I even heard a popular doctor on Instagram add brain death to that list.
I know. It's a little crazy. So I know where some of it came from. I don't know where the rest of it came from. So should I just begin from the beginning?
Yeah, I just wanted to say, like, what is that accurate? Were you surprised with the depiction? And then we'll go into like what you studied and how it worked.
Yeah. So it's not accurate. I wish that we saw that kind of data. I wish that we had those kinds of results. I do think that there's more safety associated with hormones than there is risk, especially during that time of perimenopause. But just because I believe that, I can't say that that's what our data showed. And the whole reason we did the study was because I have this hypothesis that this is a safe time to start hormone therapy. But as a scientist and a physician, I can't say those results are based on our data. And so I think what happened was my student, she's a master's in public health student, and she's combining that with her undergraduate degree in anthropology. She was speaking to the Menopause Society about hazard ratios, and she was trying to describe a 0.6 difference. And when she updated the data, we actually only found a 0.3 difference in hazard ratios. So risk that something could happen based on this really short confined period of time. And this somehow got extrapolated to 60%. And it wasn't right. It wasn't correct. Unfortunately, it got replicated. It was published on the Menopause Society's website without involving me, who was her supervisor, without talking to our media group at the university or at my hospital. It was a little bit questionable. There were people who commented on the study who clearly didn't look at the study because they said it was observational data, but it was retrospective data from a large database, right? So lots of problems with this. And the sad thing is, once it's published, it's out there and people were able to run with it. So lots of people then took up, oh, this 60% reduction across the board, which doesn't even make like statistical sense, right? If we were looking at three different things, heart attack, stroke, and breast cancer, there's very little probability that we would find the same number of reduction for all three things, right? Like statistically, it doesn't make sense. It was just a misinterpretation of the statistics, unfortunately, and maybe a misrepresentation or overstating of the conclusion. And so that's unfortunately where that came from.
I want to go into exactly what you studied, but first of all, just you as a person who's doing work, what is your reaction when you see it take off like this?
I was excited to see that people want to talk about it. I think that's amazing because this is a really important topic. It's been understudied. I like to see more people doing research in the area, but it has to be done correctly. And so I was super excited to have the opportunity to speak to people about it, talk about this. The whole point of the research was looking at menopausal hormone therapy during perimenopause before menopause occurs, because this is what I see in my office. So I see women coming in all the time in their 40s, in their early 50s, who have not yet gone through the full 12 months of no period or the actual, diagnosis of menopause. And they're still symptomatic. And it's sometimes like when the worst symptoms exist for them. And so that's what I want to see addressed.
Yeah, I remember when I was in perimenopause, I asked my gynecologist about hormone therapy, and she said, oh, no, like I can't prescribe you anything until you've gone through menopause. And this is still a common belief system. Some people really believe it. And it's not that they're misinformed. Some people believe that you really shouldn't start it till after, but you're prescribing it and you see that it helps.
And Exactly. I think it's an old school way of thinking, unfortunately. It's not based on reality. It's not based on like medicine, really, or what we even see clinically. I've had so many women tell me, well, I came to find you to get hormone therapy because I've been turned away by three other people. One person who said, I'm not having enough hot flashes. I need to have 10 hot flashes a day, not 9 hot flashes a day before she'll start me on hormone therapy. Several people who say they told me I couldn't start because it hasn't been 12 months without periods, or because I still get my periods and my only option is a birth control pill, right? Which also is not true. I've had people say, oh, my doctor said if I was going to start hormones, I need to have an ultrasound of my uterus every 6 months. So it's kind of wild what is being told to women out there. And so that's also why I wanted to do this research, because we have the treatments, we have the medication. And I think it's just that people are interpreting some sort of guidelines, or they're making these guidelines in a way that doesn't reflect reality and is a disservice to women.
You know the feeling when you tried all your health trends, but you're still tired, foggy, or just not yourself? It's not your fault. True Health starts deeper at the cellular level. Enter the first ever longevity gummies powered by MitoPure. They're the only clinically proven urothalin A gummies designed to recharge your cells, boost energy, and help you feel strong and vibrant from the inside out. They taste great. I've tried them. They're vegan and clean. And MitoPure's own testing shows they can add up to 12% more muscle strength in just 16 weeks. It's like giving your body a daily cellular tune-up. If you want to feel energized now and as you age, click the link to timeline.com in the show notes and use my code HOTFLASH for 20% off your first order. That's timeline.com and code HOTFLASH for 20% off your first order. So what did you set out to study? What did you study? And what did you find?
Yeah, so what we actually did was we looked through this huge retrospective database, that uses electronic medical records. And we looked at women who were started on hormone therapy before they were officially menopausal. So looking at this 10 years before menopause, where we see symptoms show up. It could have been 2 years before menopause. It could have been 8 years before menopause, but that was the age that we were looking at. and then compared them to women who were 10 years post-menopause, which we know from the Women's Health Initiative is the safest window of opportunity to start women on menopausal hormone therapy when we're comparing them to older women, right? So there's this comparison where we know it's safest to start within that first 10 years compared to women who are 10 years and beyond. But we're asking the question, what about the 10 years prior? So theoretically, you would think these are healthier women. It's going to be even safer, but we don't really know that for sure. And so that's what we wanted to compare. So is our hypothesis true that this is the safest time, that we don't see any increased risks of heart attack, stroke, or breast cancer? So we only could look at the incidences of those things based on diagnostic codes. And so if the healthcare professional who was seeing that patient didn't code their visit correctly, our results would be influenced by that. But the advantage is that we're looking at such a huge database that it should sort of kind of wash out some of those inaccuracies or those one-offs and give us at least some patterns or some signals of where we should be doing more research. And so what we found was that there was a slightly lowered hazard ratio for women who were started on hormone therapy during that 10 years before menopause period compared to those who were started 10 years after menopause for breast cancer. And then it was pretty similar hazard ratios for the women experiencing stroke and heart attack. And they were very low numbers to begin with, very infrequent incidences of either of those health conditions. Now, the other huge caveat to it is that we were not following these women for 50 years. We're only following them really about 10 to 15 years because of the limitations of the database. So it could be that the women in either group will experience more of those health conditions if we continue to follow them. And so that's where there's limitations to the data. But at least for those initial years, we're not seeing huge increased risks of those things. And that's what I wanted to look at. Is this just as safe as starting it during that 10 years of window opportunity after menopause?
You set out to look at, I hope I get this right. You set out to look at any increased risk of those things by going on hormone therapy earlier. And then somehow it became there's a 60% reduction in those things by going on.
Right. So you could see, yes, you're seeing right away why this was completely twisted. And I'm not against the messaging that, hey, let's look at starting women on hormones, right? That's the whole point of doing the study. I do believe it's probably more safe than it is risky, but we can't overstate the conclusions from a very limited database.
I saw people saying 120 million women, right? And can you just sort of couch that for me? Because that's wow, 120 million women in a 60% reduction. I have to pay attention to this. So can you sort of just...
I know. And even when I did some interviews and really thought that I was clarifying what that meant, I still saw it printed incorrectly. So the database has 120 million people in it, men and women. And from that database, we then drew out the individuals who fit our criteria of being 10 years prior to menopause, 10 years after menopause, and started on hormone therapy. And that was only about 150,000 women. So it's still a large number, but it's very different from 120 million.
What surprised you out of this? Your own findings, not the reaction to it.
I mean, it didn't really surprise me to find this. I expected to find that there wouldn't be any increased risk. I figured that as much, that, these are young women. And again, we're only looking for this short amount of time. And so probably we're not going to see anything. So I wasn't too surprised by that. I think in general, there still were numbers of women who had breast cancer in both arms, right? And still in that short amount of time. And so I think a lot of people are saying that estrogen does not cause breast cancer. And I would love to be able to say that, but we know that breast cancer for many cases is estrogen responsive. And so I don't think it's responsible at this point to say that there's no correlation between estrogen and breast cancer. Unfortunately, we know that there's genetics involved. We know there's environmental reasons, and estrogen might be part of the environment, especially for estrogen responsive breast cancer. As a gynecologist, I did my training where we had to rotate through GYN oncology. and saw lots of women suffering with endometrial cancer, lots of women with ovarian cancer. There are a lot of estrogen responsive cancers. And that is the huge asterisk that I feel like we can't forget about, because we can do as much as we can to prevent cancer through our lifestyle, our, being healthy, not being sedentary, avoiding, foods that might increase our risk as much as we can, as much as we know about that, right? Which is still even very limited. But there are genetic factors and there are other environmental factors. And unfortunately, I think estrogen, we can't count that out. We can't say that it's going to reduce your risk when we know that these cancers are estrogen responsive. And that's the huge thing that I don't want to be thrown out the window with everything. And, if you want to talk about like the FDA changes to the black box label, I am thrilled. I'm thrilled that they're taking it off of the vaginal estrogen prescription in the US, because that never should have been there. We don't see vaginal estrogen associated with any of those cancers. We don't see it associated with heart attack, stroke, or blood clots. And so it never should have been in there. But I don't know that we have enough data to say that there's no link to estrogen. I do think that it's the physicians and the health and the advanced practice providers who should be having those conversations. I think about my patients like I think about my family, and my sister has a estrogen responsive uterine cancer, and I would never want her to think that she should have started estrogen and it would have reduced her chances of having that cancer, right? If she had started systemic estrogen in perimenopause, it would have much worsened that cancer. And yes, what she has is rare. It is a rare aggressive form, but it would have really made her situation much more dire. And I'm grateful that she's with us today, still battling the effects of it. But, that would have been the wrong message for her. And so I want to make sure that we're still being responsible to women and we're still giving them all the information we have and not, again, overstating what we don't know.
Yeah, this is a thing that, as a journalist watching it, it seems like it's a whole group of people who are overstating it. I see women asking doctors on social media, does it increase my risk of breast cancer? And just them writing no. Like there's no increase rate. In this quarter, you're almost like a bit of a dummy if you have that fear. And I just wondered, I know there's doctors who are much more responsible. Every profession has these disagreements, but I just wonder, how you feel.
I mean, I have fear associated with hormone therapy for menopause that we don't have associated with birth control pills. And so I think for me, I don't want women to be unnecessarily afraid. I think there's so much fear about systemic hormones that came from the Women's Health Initiative that has done a true disservice to generations of women. And I think that is wrong. And I think that we have this fear associated with menopausal hormone therapy that is not the same as the way we think about oral contraceptive pills, for example, where the hormones are not that different from each other and the effects are not that different. I mean, they are different, right? And so I talk a lot about how that treatment is different, but the fear should not be so different between these two things because we're using medications to make our quality of life better, right? Whether it's about preventing unintended pregnancies or getting through your day and getting sleep and improving your quality of life and really taking care of this time of a person's life. But I also really do believe in science. And I feel like if we say that everybody should be on estrogen, we are going to see more estrogen responsive cancers. And yes, there's an individual's choice that goes into that. And so I'm glad that conversation is now moving to the physician and the PA and the NP's office instead of being on the black box label that just terrifies people. And so I think it's a step in the right direction, but we do have to be careful about overpromising.
Yeah. So in your study, it seems to focus on estrogen, but what about synthetic versus bioidentical?
Yeah.
Those separated out, progesterone, progestin, how was that all involved?
That's a great question. So in the database, we found it difficult to separate out the progestins because of the overlap with oral contraceptive pills. And we wanted to make sure we weren't pulling records of anybody that was
using an oral contraceptive pill. We wanted to make sure it was truly just menopausal hormone therapy. So for that reason, we only looked at estrogens that we could conclude, our typical treatment for menopausal hormone therapy. What I'm doing now is going back through the same database with someone who's got a little bit more expertise than I do. And we're going through together to see if we can figure out a better way to include those women who are on estrogen plus a progestin versus just estrogen alone, because I think that data is really important. When we look at breast cancer results, we do see that we see a higher incidence when someone is on a progestin and not just estrogen. And so I think that's an important factor. And so I'm hoping that we can pull that out with her help. This is where this goes from being a poster to the manuscript. The manuscript is hopefully going to be much more granular, much more robust data. And I'm pulling in an expert who's very good at looking at this database. And we're putting our heads together where I'm the clinical person and she is the epidemiologist.
So you didn't separate out bioidentical or synthetic estrogen. They're sort of together. And if these women didn't have a progestin or a progesterone, does that mean they had a partial hysterectomy then? They didn't have a uterus?
No, we didn't exclude people if they were on a progestin. We just didn't use that as an including factor because it got to be too muddled of a picture, especially at that age range in women's 40s. There's a lot of women who are on progestins for heavy bleeding or for fibroids or for other gynecological issues. And so it just got to be a little bit too muddled to be able to tell. So we didn't exclude them if they were on something, but we didn't specifically include them.
So they were just there. Like they were there if they were on it, but the important thing was they were on estrogen. You didn't separate anyone out. It seems interesting to me that I'm still seeing new studies coming across in 2025 where the researchers aren't separating out bioidentical and synthetic. Have you noticed this? Is this an issue?
I mean, it gets tricky in terms of the terminology as well, right? So bioidentical is a hormone that is supposed to match what our hormones are already inside of our body. And there are synthetic hormones that are bioidentical, right? Now, we're not including compounding hormones in this database because they are not prescribed the same way. So they don't get pulled into the electronic medical record in the same way. And so a lot of compounding pharmacies will say that their hormones are bioidentical and prescription hormones are not, but that's not true. Lots of prescription synthetic hormones are actually made to be bioidentical too.
This is crazy about the research then, when you think about it, that we're drawing conclusions from people who are on sort of the FDA approved kinds, but there's millions of women on the compounded kind. This is, I don't know. It just seems crazy to me that we're drawing so many conclusions when this isn't being studied. And I'm no scientist, but this doesn't seem like it's being studied in a fully proper way.
Yes. And this was one of the points that I've been trying to get out there with this publicity that's come around this study is that the data is there. If you think about all of the compounding pharmacies that exist around the world and all of the people who've been on them, we have this retrospective data and we need people to start pulling it and publishing it. Right? Because it's out there. People have been using compounding hormones for decades now. We have lots of other databases aside from the one that I used. There are individuals or practices that are treating thousands of women and they have lots of data. Like we should all be doing this research. It shouldn't just be my pre-med student who's doing it as part of her class.
That's a big responsibility. Yeah, that's really interesting. Someone that saw this. Tell me that.
Yes. Yeah. So the crazy thing is talking to people who heard about this study and didn't realize that it was mine, right? And heard the misinformation or the overstatement of the results. And so one of my friends said that she saw it and she thought to herself, oh, great. I'm so glad that I'm on hormone therapy and I'm glad that I started it early because look, there's this 60% reduction in breast cancer, heart attack, stroke. And like, it just gave her this feeling of relief or sort of reassurance in the decision that she had made. And then she just continued scrolling, right? And she didn't give it a second thought. And I think that's where the potential danger is that once something is out there, once that information is out there, regardless of accuracy, it is basically either validating or invalidating what people are already doing. and then they continue on with their life. You know, we see this in politics too, which we're not getting into today.
No, no, but
that's
I mean, we all do it. We're like, okay, that makes me feel better. Oh, that makes me feel worse. Oh, that makes me,
yes,
no wonder we're all going crazy because we're just like, uh, but I did want to,
exactly.
in, in a study, say there was a study that came out tomorrow that did say, hey, hormone therapy gives you a 60% reduction in breast cancer, stroke, and heart attack. I think people think that means that them sitting there when they see the message that, oh, if I go on hormone therapy, it is cutting my own personal chances of getting those things by 60%.
Right,
That's a very
right.
confusing point. But can you just tell us what you know about that?
Statistics didn't come easy to me either. I did a master's in public health, and statistics was very challenging. And we see these numbers that are actually, they show us maybe a 6-point reduction in risk or a 0.6 reduction in hazard ratio, right? When we're talking about ratios. And somehow people take that to be a 60% reduction in their personal risk. And that is not the case. We're talking about how often these events occurred when we look at large numbers of people. And so you might be able to say, okay, if I start hormones and I'm looking over 10 years of my life, then out of 100 women in a similar situation, this is how many will end up with breast cancer, right? That's kind of what we're doing when we're talking about population statistics. But it does not mean that you are influencing your own health risks, right? And you have to remember there are so many other things that go into a person's health. And most of those things we've excluded because that person wasn't eligible to start hormone therapy anyway. And it's ironic because this is what happened with the Women's Health Initiative. So this awful study that we all say was awful because it scared people off of estrogens, it was actually misconstrued the way people looked at the absolute risk versus the relative risk of breast cancer, heart attack, stroke, etc. And people in the media, unfortunately, extrapolated it to be percentages and percentage increase. And then that was then translated to the lay conversation of estrogen causes breast cancer, estrogen causes stroke, right? Like there's it's all of these things where we're looking at correlations and we're looking at population data and how often something is happening in this large population. It doesn't mean that individual's risk is necessarily changed. We are just looking at chances here.
I'm so glad you brought that up because one of the criticisms of that arm of the Women's Health Initiative was that it used relative risk. And the same people who will criticize it for that use relative risk all the time because it sounds way better.
Yeah.
You're not going to make an Instagram reel about a point.
You should. I know. And I work with epidemiologists. Every time I do a research study, we have a statistician or an epidemiologist who's on there because it is really complicated. And so I am not that person, but I feel like they help us to make sense of this data. And again, sometimes when you're making your own health conclusion, like we don't have all the information, right? That's why we're so behind in women's health research. And so sometimes we only say like, okay, well, out of 100 women, if they were to do this, this is what's going to happen. And that's the best way for us to make a decision. It doesn't mean it's the only way. And it doesn't mean that it's really personalized, just giving you a little bit of an idea.
If a woman came into your office and she said, I'm feeling pretty good, I'm fine, but I hear that hormone therapy will help me prevent all these diseases, what would you say to her?
Oh, it's such a good question because I hear this all the time. And I'm grateful that the conversation is happening. So don't get me wrong. I am not a hater. I am not one of these people on social media bashing everybody's like proposals to be using hormone therapy if they need it. I think that there's so many really interesting things about how it may be linked to decreased cardiovascular changes, how it might be linked to the brain. Like, I think this stuff is fascinating and I love the research about it. And usually what I tell those women who are not having symptoms is that we don't have the conclusive data yet. And if she doesn't have any medical reasons to not be on hormones, I'm happy for her to try it. And if she wants to be on them, and because we're hopeful that there might be some positive linkages, that's okay with me. But I also let her know that things are not as conclusive yet because we just haven't even had the time. We haven't had the research. We haven't had the number of years to follow women because we are decades behind. And I'm hoping in the future we'll have more information because I do think that there are links. We see changes in the bladder with estrogen that we don't fully understand yet, right? There's a lot out there, and we have estrogen receptors throughout our entire body. So I do think that there's going to be more promising information, but I can't tell someone you should be on this if you don't have symptoms, right? So I guess that's the difference. Like, you can be if you don't have any medical issues, but I don't say you should be at this point. And maybe that'll change in 5 to 10 years once we have more information, but that's where we are now.
Okay, so as someone's in their early and mid 40s and they're starting to experience symptoms, what should they take away from this early work that you've done?
Yeah. So I would tell them the takeaway here is to talk to their healthcare professional about menopausal hormone therapy and not just a birth control pill. And it all depends on what's going on, right? If they're having heavy uterine bleeding, hormone therapy might not be the most effective at controlling that. They might need something like a birth control pill or a Mirena IUD, or, there's lots of other things that I would say. If you're having heavy bleeding, please see a gynecologist. There's a whole workup that needs to be done, especially if you're in your 40s and experiencing that. But they should know that if they did not do well with birth control pills in the past, that they might actually find good symptom relief from hormone therapy. I would caution them from taking any safety data from my study. I think wait till we do our manuscript to really, have a little bit more information. Wait till there's more prospective trials. Don't conclude anything from my study, but let it just be an idea for you to ask your healthcare professional, hey, could this help me with my symptoms more than birth control pills or more than something else? And that answer might be no. It might be, you know what, actually, I'm going to recommend something else because you need a good contraceptive, and menopausal hormone therapy is not a contraceptive, or again, because of that bleeding issue, which unfortunately I see a lot of in my office as a gynecologist taking care of women in their midlives.
Do you have any theories about the bleeding, about why that's happening?
So I do see a lot of women with adenomyosis, and I think it's a very common thing that's not talked about that much because there's much more information now coming out about endometriosis.
What is
adenomyosis?
Sorry.
Yeah, adenomyosis. Sorry. What happens is the lining of the uterus starts to grow into the muscle of the uterus, and it makes the muscle of the uterus a little bit more spongy. It doesn't work as well when it's contracting or cramping to stop bleeding. And we see this a lot in women in their 40s and 50s. So I will tell you, probably most of my patients that I'm taking care of for heavy bleeding are dealing with either adenomyosis or fibroids. And it's just this decade of their life where those things are more common. And so getting them on treatment, whether that's an IUD, which tends to help for a lot of them, or surgery. I do a lot of hysterectomies, especially for women who want to be using estrogen during this time of their life, but are having such heavy bleeding that no medications or no IUDs are really helping. Oftentimes we end up doing a hysterectomy for them because it's going to improve their quality of life and decrease the amount of bleeding, allow them to kind of fully function without having to deal with a week of heavy bleeding each month, or the really unpredictable heavy bleeding that tends to happen in perimenopause as cycles are changing.
You mentioned, I think, in your research that about the healthy user bias, and I don't hear that talked about a lot when it comes to hormone therapy. Can you just tell us what your understanding of that is?
Yeah, definitely. I mean, I see that every day, unfortunately, because I live in Cleveland, Ohio, where there are a lot of health disparities, sadly. A lot of them are tied to economics, tied to social determinants, unfortunately. And I do see that the women who are coming in early for their menopausal symptoms and asking and advocating for hormone therapy or for options or for a conversation, they are women who are more educated, who have resources. And we know from research that those are the people who are getting treatment. So there is this healthy bias that it's the healthy women who have resources, who have access to medical care, that are getting care first and the earliest. And so it could be that even from a retrospective database, if we're looking at women who started hormone therapy earlier, it could be because they sought out that care. They were healthy enough that they were able to get started on all those things. We don't see women who already have a high risk of heart attack or who've had a blood clot in their legs or lungs necessarily getting hormone therapy early, right? There's a whole other set of barriers. So these are the healthiest women that also have access to care. And those are the people that we're able to follow. So it's definitely biased. It's not a real world scenario, sadly.
And since you've been in the middle of this you've seen how this has gone, it went a bit sideways. How is the average woman supposed to discern when some of the top names aren't getting like these basic facts right from research?
It's hard. I have told people, don't stop seeing someone for your own care. And yes, I get information from social media too, right? I could liken it to going on vacation. I look up information on social media for my trips because I see the pictures, the videos, like that helps me to think of what I want to do. But do I use that to book my hotel? No, because I know that there's an agenda behind each video, right? There's someone who's sponsoring that hotel, and it might not actually be the best place. So I'm still going to go out and figure out what I like and what I want and look at the reviews and give that discernment to what I just saw beautifully depicted in the video. And maybe it's not too far of a stretch to do the same thing when you're coming to health information. Sure, get some background information, get some ideas from social media, but don't stop there. You need to go in and get your individualized care. You have to see your own medical care provider. I know that we have busy lives. I do too. And it's easier to just kind of like get that quick fast food advice, but you do not want to go cheap when it comes to your health. Take the time to get your own individualized care. That's the most important thing.
Thank you so much. I really appreciate you breaking it down for us. Thank you.
Absolutely. Thank you for inviting me on and bringing awareness to this really important topic.
Hotflash Inc was created and is hosted by Ann Marie McQueen, produced and edited by Sonia Mack. The information contained in this podcast is intended for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider, read all labels, and heed all directions and cautions that accompany the products. Information received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, i.e. menopause or anything else, or any healthcare questions, please promptly see your healthcare provider. This podcast, including Ann Marie McQueen and any producers or editors, disclaim any responsibility from any possible adverse effects from the use of any information contained herein. Opinions of guests on this podcast are their own, and the podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about a guest's qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have direct or indirect financial interest in products or services referred to herein. This podcast is owned by Hotflash Inc Media.